So I would just introduce myself. I'm from University of Washington, and this talk is focusing on so-called vessel wall. So when you look at vessel, the stenosis clearly is a major target. But when you actually look at, if you want to image vessel wall, there has to be a reason for it. I think in Dr. DeMarco's talk, he already alluded to about this, some of the things that related to this. I'd like to show this picture. This is actually from Dr. Salona. This is a carotid artery specimen. And then when you look at this, the stenosis you see in this versus what you see as the plaque itself, these are really very distinct features. One is the impact of this lesion leading to stenosis. The other one is the plaque itself. The plaque can actually build quite sizely without impacting lumen. So vessel imaging really is trying to provide that information. And the other thing is, these are 3 carotid specimens, and they showed similar levels of stenosis. But if you look at the composition, they actually look very different. So the question really becomes, if you have the same amount of stenosis, but you have different lesions, should they actually be treated the same way? Currently, the guidelines certainly will be, but the question then is the nature of the lesion, whether they should actually change the clinical practice in some way. And you have seen this picture of trying to define this as something called vulnerable plaques. And the concept is that these are the plaques that lead into so-called plaque rupture and that lead into clinical events. And if we have a better way of defining this with imaging, then we should actually have a better way of treating them or identifying this as so-called people who are at risk of leading to clinical events. So this vessel imaging really is focused in that fashion. If you look at what's of interest from imaging's point of view, this is sort of the consensus of this community, is we want to look at whether the surface is ruptured, whether there are fissures, ulcerations, or juxtaluminal calcification, and whether the plaque is inflamed. And the third one is that whether we can detect high-risk components such as intraplaque hemorrhage and also lip-rich necrotic core and so on. And the last one is the so-called vessel remodeling, meaning the vessel actually may maintain its lumen size and developing a plaque at the same time, and how we can actually identify this more accurately with imaging. So even though the title of my talk is actually focused on head and neck, this type of imaging can actually be done in many vessels. And frankly, I think that coronary arteries will be a very interesting place to look at vulnerable plaques. And the other thing I'd like to highlight is, even though that vessel imaging started as a focus of looking at atherosclerosis, for now that the application of this has been extended into many different areas, especially in the brain, that you can actually look using vessel imaging to try to differentiate whether this is caused by plaques or by other so-called vascular pathologies in the vessel wall, such as vasculitis. And another thing of this is I'd like to highlight here is there's this so-called vessel wall working group that's organized by American Society of Neuroradiology. They recently have 2 papers published. One is based on carotid artery, as shown in this paper. And for the carotid artery, the main focus has been very much on atherosclerosis or high-risk plaque detection. And this is what the paper basically called for, of what need to look for. If we have imaging, what information we should provide. And for intracranial artery, this is another paper also coming out from this vessel imaging working group for intracranial arteries. And this is published in 2017. What it highlighted, number one, is that this is likely going to be useful for imaging to differentiate different types of vascular diseases in the brain. The second one is whether this may actually play a role to identify either symptomatic or asymptomatic subjects with established atherosclerosis but without evidence of stenosis. And in those, the vessel imaging may actually play a good role. And furthermore, there are other information provided here of what this may actually be helpful. So if you look at how this all started, this vessel imaging in MR started from carotid artery, and for the reason of this is a main artery leading to stroke. And also this is an artery that you can actually, the plaques can be fairly sized. And what is a summary of this is, if you want to do this, you basically want to have this, one is to have so-called combined black and bright blood. And you want to have an effective way to suppress the blood flow in order to get good vessel images. The second one is you want to have multi-contrast combination, either pre and post contrast enhancement or T1 and T2 combination in order to differentiate key components of the vessel wall. And another thing I'd like to highlight here is this also is benefited from using surface coils in a carotid area where you can actually get better signal to noise and better resolution. The other thing in relationship to this is in a carotid artery, because you can operate on these patients, you can get the specimens, therefore you can actually do imaging versus histology validation. This is a big feature of what MR is able to show here. That in this case, what you showed, a panel of images, is using we did this in Seattle using a technique we call SNAP. Basically, it's a technique to look at detection of stenosis and also having heavily T1 weighted vessel imaging acquired at the same time. And this is what you get in vivo before the surgery. And this is the specimen at the surgery when it's acquired. And this is what you see in histology of what they look like. And moving into intracranial artery, as Kevin alluded to already, is the question really becomes of we want to have really high resolution black blood imaging. In this sequence that we basically showed that you can do this with 0.4 millimeter isotropic 3D acquisition. And this particular case is actually, it takes more than 10 minutes to do, so it's not realistic to do. There are some new imaging techniques now can actually cut this time to 5 minutes, either through compressed sensing or through other techniques. The other thing I like to highlight in this also is when you look at this image, its background is the brain tissue versus the carotid is more fibrous tissue surrounding the vessels. Being able to identify the outward boundaries is not going to be similar. It actually, in some cases, can be quite challenging. So that's another issue for the intracranial vessel imaging. In terms of the imaging techniques, that I think the techniques has moved from a 2D based, as shown here, that we like to call this as a phase 1 of development, multi-contrast T2, multi-contrast 2D imaging, to 3D imaging, as shown here, that this is you can do this both intracranially and also carotid. And now you can also do this in one setting, that you can do ultra-fast 3D acquisition to cover everything in one acquisition. The 2D imaging, as shown here, that basically is the most standard and widely available way of doing that. And the challenge of this is this tend to be fairly long. Overall, if you do multi-sequence, and this can be larger than or more than 30 minutes, and it has a limited coverage, and the slice thickness is about 2 millimeters. And in this this is a so-called summary paper from the working group in ASNR, and this actually listed the so-called, based on 3 main manufacturers, existing protocol, existing imaging sequences, what you can do in terms of using non-contrast versus contrast 2D imaging. In terms of 3D imaging, this is a panel of carotid artery. And the techniques we did here is, the first one is called 3D merge. It's a gradient echo-based sequence. The second one is a black blood, either T1 or T2. And this is usually called Vista, Space, or Cube, depending on which manufacturers you're doing. The third one is SNAP, I just mentioned, is looking at so-called intraplaque hemorrhage. These are the examples of using this a combination of 3. What this does is this can give you very quick coverage, acquisition, and large coverage of the carotid region. And you can get an isotropic voxel of 0.6 to 0.8 millimeters. And in the carotid paper from ASNR, they also have published imaging protocols based on existing products from main manufacturers, what you can do in terms of 3D vessel imaging. For intracranial, that this is some of the early examples of looking at using 2D techniques to look at intracranial, as shown here. The acquisition time can be long if you do multi-contrast, but as you can actually see here, as long as you can get a good cross-sectional view of a certain segment, you can get beautiful images of the plaque. The challenge of this, however, is you have to know where to look. And if you don't know whether there is a plaque, how do you place those, the particular planes for imaging? But in any case, this is an imaging protocol designed and also listed in this opinion paper of what you can do if you do 2D imaging. So this needs operator dependent, and also you need good information where to look. And the other way for intracranial vessel imaging is shown here, that you can do 3D time of flight, and you can do this black blood, such as using VISTA, for example. And you can also do SNAP. In this case, you can actually see that there's an intraplaque hemorrhage in intracranial arteries, as shown here. This 3D imaging, also there's established so-called protocols in that paper, as shown here, that based on time of flight, T1, and also based on contrast. One thing that is fairly common in this vessel imaging is the contrast enhancement plays a very key role, because it can help you to identify this so-called intraplaque hemorrhage. So the enhancement is very useful. And then for intracranial vessel imaging, the enhancement is even more useful because it may actually help you to identify this so-called inflamed arteries, such as in vasculitis, that the enhancement pattern itself becomes a critical information. And the last part of my talk, I will just focus briefly on what is the analysis done in looking at vessel wall. This is a cartoon showing that what you can do quantitatively in terms of measurement. One side of the measurement is really looking at plaque burden. You can measure areas of the plaque, areas of lumen, and then there's something called normalized wall index, is trying to adjust vessel wall size and lumen size to give you a so-called plaque burden measurement. And in addition to this, you can use different softwares to look at so-called plaque compositions and reporting where things are in different locations. And this is for intracranial artery because of the tortuosity of the arteries, and also because of the lesions may actually present at different locations, not necessarily, like in a carotid, it's almost always focused at a carotid bifurcation. So this is a technique we have actually developing called 3D cascade. Is trying to use this so-called vascular information, centerline information, to actually identify lesions at different locations and quantify them. So with that, I'd like to summarize the vessel imaging of the head and neck. In terms of the technology, I think that there will be issues to consider for whether you use coils, and especially for the carotid arteries, that this is beneficial. And even for intracranial application, that having a good signal-to-noise coil, such as 32-channel coils, may actually be quite important. The second one is you need to have good imaging sequences for black blood, and especially for brain application, they need to be time efficient with a good acceleration. And image processing tools are critical for quantitative information. And then I think that the other challenge now is that the radiologists are really, in general, not trained to review this type of images. So I think training is actually an important issue. In terms of the application, I think one area of this is to look at so-called lesion composition, or defining the nature of the vascular wall based on what we see in images. The second one is for high-risk plaque detection. With that, I'd like to thank you for your attention.